Welcome, everyone. Welcome to Aspen Brain Institute's Expert Speaker Series 2.0. Welcome to our growing community of global seekers, seeking to be educated and delighted at the cutting edge. And hello to people all over the US from 47 US states and 103 countries who have registered for this series. Our last series, 1.0, we had 12,000 people register for the series, and we think about 16,000 or more will register for this series. So we're very excited. Thank you all for tuning in. We're offering our new free series in order to build an online global community focused on brain health. We would like to thank Lugano Diamonds for their generous support as our national underwriter. And we thank Lugano Diamonds again for choosing Aspen Brain Institute as a nonprofit worthy of their values and their support, and for making our Zoom expert series free to the public and able to be viewed worldwide. We also thank Alpine Bank for their generous sponsorship. They're the greatest community bank in Aspen. And thanks to our partners at Brain Futures, who are doing important work in advancing the practical application of new scientific understanding of the brain and learning in K-8 schools. At our Expert Series 2.0, you will hear global leaders, deep thinkers, technology experts, cutting-edge scientists, top-notch doctors, and extraordinary creatives. We hope their insights will transform how you care for your brain today that your 80-year-old brain will thank you for tomorrow. This Expert Series 2.0 underscores Aspen Brain Institute's mission, and that is to share access to the top minds in scientific research on brain health, to increase brain health literacy across the globe, and ultimately to create a brain healthy planet. It's my honor and privilege to bring you these new episodes. Let's see what we can learn and explore together. And now to our expert series. I want to introduce Dr. Ronnie Stangler. She's the chair of Aspen Brain Institute Scientific Advisory Council. And she is going to introduce our next expert speaker, Dr. Robert Green. So Ronnie, take it away. We want to hear more about both of you.
Glenda, thank you, and welcome to you all. It is indeed my pleasure to introduce our ABI audience to Dr. Robert Green, truly a pioneer in applied genomics. I've had the honor of getting to know Dr. Green through our common work in genomics with complex families. Dr. Green is professor of medicine at Harvard Medical School, a medical geneticist and physician scientist who directs the Genomes to People research program at Brigham and Women's Hospital, the Broad Institute, as well as Harvard Medical School. Dr. Green's research focuses on the acceleration of evidence-based implementation of genomic medicine. He led the first experimental trials disclosing common complex disease risk, the REVEAL study, and the first prospective studies of direct-to-consumer genetic testing services. He currently leads the first randomized trials exploring the implementation of medical sequencing in adults, also known as the MedSeq Project, and newborns, the BabySeq, short for sequencing project. He has published over 300 scientific papers, and many more are certainly coming. Dr. Green has been prominently featured in the most greatly esteemed national and international media, too many places to cite. Robert Green is a global medical visionary who is helping us utilize genomics in a new, rich way, incorporating it as a transformative science to enrich and extend healthy lives. And that is what we will be discussing today. We are so proud to have him join our ABI family. Dr. Green.
Thank you, Ronnie. That was an amazing introduction. I hope I can live up to it. And I just really want to thank you and the work that you do in bringing genomics to so many families. Glenda, this is an amazing series. Thank you for inviting me to be part of it. And you and folks like Emily Goldmeers have just been creating this intellectual fertilization for people, including myself as an audience member on previous and future talks. So this is really fun for me to be part of this, and thank you for inviting me. It is the Aspen Brain Institute, and I'm going to talk a little bit about brain science because I originally trained as a neurologist. And then about halfway through my career, I realized that many of the diseases I was most interested in, including Alzheimer's disease, were actually genetic conditions. And that got me started on a learning odyssey that turned my life around. I went back into residency halfway through my career, was taught by people much younger than me, and ended up becoming board certified in medical genetics as well as neurology. So I'll be touching on this a little bit today, but my interests have evolved from healthy brain science, which you will hear a little bit about, to healthy human science, which I'm now convinced will be enhanced by genomics in ways both small and incredibly large. And so I'll share my screen to start off with some slides here. And then I'm really looking forward to the conversation that we'll have together and to people's questions as we go. So, you know, extending your life through preventive genomics means to me that every illness that we have that has a genetic component, we are going to be on the brink of predicting, risk stratifying, and preventing. And that's what I'm going to talk about today. Although I'm going to start off with a kind of introduction to genomics because it can get a little tricky if you don't know the terms. I would like to make sure you know that I have the support of National Institutes of Health from actually 5 different institutes have funded us in recent years: the Department of Defense, the Broad Institute, the Snite Foundation, and the Franca Cesani Fund for Preventive Genomics, as well as you should know that I advise some companies, and I have co-founded a telemedicine genetics practice called Genome Medical, which I'm very proud of. The program that I run is a relatively small core program, which we cheekily call Genomes to People. And our focus is the medical, behavioral, and economic impact of genomics. And genomics stretches across a wide variety of purposes and indications. Most of the history of genomics has been around making a molecular diagnosis. We have generated our projects with this core team, and we give them cute names. So I won't go through all these, but our flagship projects are these 7 projects. I'll be talking mostly about MedSeq and BabySeq today. But I will say that the REVEAL study I'll touch on was the first study to disclose APOE. And that is a genetic marker for your risk of Alzheimer's disease. And if you were here last week, you heard Rudy Tanzi talk about different genes for Alzheimer's disease. This is the most common genetic variant that indicates risk for Alzheimer's disease. And that's actually how I got started in this whole thing. We're also a program that brings in lots of people, trainees, students, collaborators. So you can see that the people whose faces are circled are a part of our core program, but we build these teams around each one of our projects. This project, for example, I won't be talking a lot about, but it's the first project to offer return of genomic results to an all African American population. You've all heard about the disparities in healthcare. These disparities are even greater in genomics, where it tends to be the sort of wealthy, forward-looking people who are on the cutting edge of trying to get genomic information and purchase it, and it's not covered by insurance. But I'm really proud that we have the very first study to be returning genomic results in a large research study to the Jackson Heart Study in Jackson, Mississippi. And we're also helping the gigantic 1 million person All of Us research program return genomic results. First time this has ever been done on a countrywide basis. We're helping, of course, our own partners, or Mass General Brigham Biobank, and we're helping the Google Verily Project Baseline figure out how to return results. Because as you're going to see, there's a lot of controversy about this. So our team actually collaborates with many, many people, and I'm quite proud of the small footprint we have, because nothing's more valuable in an academic center than real estate, but our ability to collaborate with many, many brilliant people whose work is going to be represented during today's talk as well. So let's quickly review the basics for those of you who don't think about genetics every day. And hopefully this will make the rest of the talk really fun to follow. And just as a reminder, your DNA is a long string of chemical letters. It's like a code. And most of that code, 99% of that code, is exactly the same in all human beings. But there are places in that code that are different, and those are called variants. And it can just be the substitution of a single letter, like in this human being, that G right here is, instead of being a G, is an A right there. Or this T right here is an A right here. Or it can be that pieces of the code are actually cut out or duplicated. So there's a lot of ways you can have variants, but that's what we're really talking about when we used to talk about mutations, but that kind of got a bad rep. So now we talk about variants. And most of the variants in human beings are actually completely harmless. They have patterns. These are the variants that Ancestry uses when they want to say, you know, you have a particular ancestry group, or they're the variants that we sometimes use to confirm paternity. They don't have anything to do with disease. But there are other variants that are very specific, and they have greater or lesser influence on disease. So this DNA, this long string of DNA, is packaged in your chromosomes, and it has about 3 billion subunits. And as a nice mnemonic, it cost about $3 billion to sequence the very first genome. And within that long string of letters are 20,000 genes, which are little stretches of that gigantic alphabet that code for the proteins, code for every protein in a human being's body, and create the building blocks for your entire body. So it's kind of counterintuitive, because this whole genome, all these different letters are there, but only about 2% of that entire genome encompasses the 20,000 genes, which we call the exome. So you've got your whole genome and you've got your exome. And then within those 20,000 genes, we only really understand about half of them. And of those half, about 5,000 are firmly associated with human diseases. So basically, medical genetics has been sending single gene tests and some panels within these little circles in the bottom for most of the time that this medical discipline has existed. And if you go away with nothing else tonight, I really want you to go away with the difference between genotyping and sequencing, because I can't tell you how many times I've asked an audience, how many people here have been sequenced, and a whole lot of hands shoot up, which are actually the people who've received direct-to-consumer genetic testing. And both are valid technologies, but they're very different. Genotyping, which is in the cost range of about $50 to $100, basically looks across the entire alphabet of this DNA, the book of your DNA, if you will, and looks for some specific words within some specific variants within that book. So it's simply not comprehensive. Sequencing actually decodes every single letter on every single page of that book. And depending on whether you are getting whole exome or whole genome sequencing, depending on the quality of the laboratory, and depending on how much interpretation you want to do, That can cost anywhere sort of from $500 for the genome itself with no interpretation to $5,000, $10,000, $15,000 for sequencing. You can really go very, very deeply into this if you want to. So it's important to understand that direct-to-consumer testing, what you get from Ancestry.com, what you get from 23andMe, is all genotyping. That's why they can sell it at this price point. I'm not a DTC hater. I believe, as you'll hear in a few minutes, that direct-to-consumer genetics has opened our eyes, disrupted our thinking, created opportunities for the democratization of genomics. But it is important that you understand that with genotyping, any genotyping, what you can get from this is limited, whereas you can get much, much more from sequencing. Sequencing has been coming down in price, dramatically coming down in price. And it turns out that when we generate all that DNA, it's actually now processing the data, storing and processing the data. That is the bottleneck for how we apply genomics. You would think that it's a big data problem, and you would think that all you have to do is kind of put all those variants into a computer and it would spit out the answer. And to some extent, that's true. We have databases now that we can take your 5 million variants. Anybody listening to this talk, we could take your DNA, put it through a computer, and we could take 5 million variants and we could get it down to a couple hundred that are suspicious. But the state of the art right now is that we still have to use a learned curation expert to take those last couple hundred variants down and generate the best quality report. And that's why interpretation is not automatic. Interpretation still requires medical expertise and input at this moment in history. Many companies say that they're going to do this, and maybe some of them will. I hope they will, but that's the state of the art right now. So we call this faster, more accurate, cheaper sequencing. We call it next generation sequencing. But you got to remember, genetics has been around for quite some time. I mean, we've been taking kids with rare diseases. We've been doing some preconception screening. We've been taking folks who are in families with Huntington disease or early onset breast or ovarian cancer. We've been testing them, usually one gene at a time with older technologies for 20, 25 years. So this has been going on, but it can now go on even faster. And if you're interested in a quick summary of what we mean by diagnosis, here's an article we put together in New England Journal, which for the doctors on the call is a good summary of how we're using sequencing for diagnosis. But sequencing has now gotten so cheap and so accurate that we're thinking of it in whole new ways. We're thinking of markers that can influence whether you take a particular medication, whether it gives you a side effect, whether you need a low dose or a high dose. That's called pharmacogenomics. We're already taking blood out of the bloodstream of pregnant mothers and actually looking in crude ways at the DNA of the fetus to understand if that fetus might have a chromosomal duplication and whether that fetus is not going to turn out well or not. And that's going to be more and more refined. And a huge area in genomics, which I'm not going to talk about today, is we're sequencing tumors. When people develop cancer, we're taking a piece of that cancer and we're sequencing the new mutations that are proliferating in that tumor, and we're targeting therapies within that tumor. And so these are all some of the exciting new things that we can do with next generation sequencing. But what I'm going to zero in on for the rest of the talk is this prediction from 19 years ago. And Francis Collins is actually still the head of the NIH. And he said back in 2001, I predict that comprehensive genomics-based healthcare will become the norm with individualized preventive medicine by molecular surveillance. And my question to you, folks who are listening to this talk, is why hasn't this happened? Why hasn't your physician said to you, have you had your genome sequenced? Let's get your genome sequenced. And I'm going to spend the rest of the talk talking about that. And the short answer is we do not yet have the kind of proof of benefit in comparison to cost and risk that is sufficiently convincing so that the somewhat conservative medical establishment and the extremely wary payer community will authorize the use of this in ostensibly healthy people. So my career in the last few years has been focused on generating the evidence that would support or refute this proposition. Now here's a quiz for you, and I'm going to ask you to, it's going to honor system quiz. I'm going to ask you to consider a percentage in each of these boxes. What percentage of people are carrying at least one monogenic recessive mutation that would not affect them but might affect their child? What percent of people are carrying an atypical response to medication? What percent of people are carrying a dominant mutation? That could be Huntington's disease, BRCA1 for cancer, cardiomyopathy, hearing loss, but it's something that's passed on potentially from parent to child with just one copy. And what percentage of us are, oh, I don't know, 2 to 3 times more likely to develop common conditions like heart disease, diabetes, atrial fibrillation, and common cancers? So jot down a percentage for each of these, and then I'll show you at the end what our research has shown, and let's see how close you get. I want to quickly speak to the myth of psychological distress. One of the first things you hear from both lay audiences and medical audiences when you talk about predictive genomics, preventive genomics is, oh my gosh, I wouldn't want to know, or if they're doctors, you will be terrifying and traumatizing anybody who asks for this information. I'm here to tell you it's simply not true. I told you at the beginning that I've worked on APOE for Alzheimer's disease, and we've written 30 or 40 scientific manuscripts, but this is one of our flagship papers all the way back in 2009 that demonstrated that if we randomize people to receive their APOE genotype versus those who did not, we actually demonstrated there was absolutely no difference in anxiety, depression, test-related distress, any kind of psychological trauma. In fact, people who learned they were at risk tried to do more, exercise, dietary changes, vitamins. And something that really put the shakes in the insurance industry, it turned out that people who learned that they were E4 positive and thus at increased risk for Alzheimer's disease told us they were going to purchase more long-term care insurance and possibly more health insurance. This has shaken the insurance industry ever since, I can tell you that. We can talk more about Alzheimer's disease, but this is what got me really excited. You know, if people weren't getting distressed by a risk of Alzheimer's disease, then I felt they weren't going to get distressed almost by anything. And it's turned out to be true, as you'll see. Then in 2007, direct-to-consumer genetic testing launched, and we were the first ones to really study what was happening there. I can't tell you how much the genetics discipline, domain, specialty was against this when it came out. It's like, oh my God, you're going to play in our sandbox, you're going to mess it up, you're not doctors, it's going to be horrible. It turns out that people did pay attention to risk perception, and it altered their risk perception, but not by a huge amount. And it turns out that people's risk perception for these common diseases is kind of pretty tethered. And direct-to-consumer genetic testing didn't sort of send them off the deep end. It also turned out, one of the predictions was, oh, your people are going to go out and get all sorts of unnecessary screening. Turns out they simply didn't. Sometimes when they got a little bit of increased knowledge about elevated colorectal cancer risk, there was a slight increase in colonoscopy. There was a slight increase in PSA screening for people who learned they were at elevated risk for prostate cancer. But you know what the most prominent thing was? People got on the internet and ordered unregulated supplements and vitamins, which we don't endorse, but was not part of what was predicted as one of the problems for direct-to-consumer testing. There was also the FDA was terrified that people would change their own medications with some of the pharmacogenomics. Turned out that when we studied customers, they actually didn't change their medication. And it turned out that some customers actually reported it, that self-reported improvements in diet and exercise. So direct-to-consumer genetic testing was not the destructive force that my discipline of genetics predicted that it was going to be. But I'll tell you what it has done. It's done a couple of things that have kind of muddied the water. I think it's done some great things. It's democratized and demystified genetics, but it's conflated a laboratory with a care provider. It deliberately conflates this. So laboratories like 23andMe, laboratories like Color, like Veritas before it halted operations, now Ancestry Health, these are all laboratories. They're not care providers in the conventional sense. They're not physicians. They may have genetic counselors working with them. And then when they decided to avoid censure by the FDA, they would hire a giant physician authorization service to, quote, order their laboratory test. But they're in the background. You don't see them. They don't take care of you. So this has resulted in a huge expansion of physician authorization services that first got started with sexually transmitted diseases and have now expanded into helping laboratories directly market laboratory tests. And ironically, though they've democratized genomics through their sometimes exaggerated marketing and through the limitations of their offering, they've actually distorted the usefulness of genetics, because you can learn some valuable things from direct-to-consumer genetics, but you don't get all the things that you get when you go to the slightly more expensive sequencing, which I'm going to be telling you about. So in a weird way, some 14 million people have gotten direct-to-consumer genetic testing, and most of them have gone, okay, so what? What did I learn that really influences my health? And I'm going to try to change your mind and tell you that you really can learn some things that will truly influence your health. Now, direct-to-consumer genetic testing got a lot of publicity, but over the years since they launched in 2007, genomic medicine has kind of been plodding along, and that ecosystem has been changing a lot too. We couldn't not be affected by the fact that suddenly there were 14 million customers who had received some kind of DNA test. There was a huge awareness shift in 2013 when Angelina Jolie talked about predictive testing for her own BRCA mutation. There have been millions of people who've gotten genetic testing as part of a research project, even though it hasn't made its way into conventional medicine yet. And it turns out there's this quiet but unstoppable ethical movement toward returning research results to research participants. And then I helped lead a kind of rebellion within the discipline of genetics, where we said, when you do sequence somebody, you got to give them something back, particularly if it's going to save their life. You wouldn't think that would be controversial, but when we finally did publish this recommendation, and with the support of the American College of Medical Genetics and Genomics, 18 ethicists wrote a dissenting paper saying we were out of our minds. And that's because where we're heading with all this is a form of population screening. And population screening is very controversial. And yet it's needed. In our biobank, half of the people we found with cancer predisposition genes that had never been recognized actually met National Cancer Association criteria, the NCCN criteria, but they had never been tested. Regular medicine is failing by its own standards to offer testing to people whom it says you should offer testing to. And the population screening debate comes down to these two sides. On the left side, the positives, is that there's a lot of people out there with unsuspected genetic disease. You can't find them, and doctors aren't testing them even when they meet criteria for testing. If you find people with a particular risk, whether it's a rare disease or a common risk, most of the time you can do something about it. You can surveil them more often. You can tell them to watch out for something. A fainting spell in somebody with a mutation for sudden cardiac death looks very different to a doctor who knows about that mutation, I can tell you that. And people are interested, and many of them, not all of them, but many of them want to know about this genetic information. On the other hand, anybody who's studied some basic epidemiology knows that if you're screening for rare conditions, you're probably going to find people who actually won't get the condition. So you're going to be identifying a lot of at-risk people who never ultimately get the condition. We really don't have proven clinical utility. We have a lot of common sense clinical utility, but we don't have proven clinical utility, and we don't really know the costs. And we've got a workforce, frankly, that is a bit wary of genetics. Most doctors, most nurses, most PAs don't want to have anything to do with it because they don't really understand it and they don't have the time to kind of get into it and learn. So the question that I've been struggling with, excuse me, for the last 7 or 8 years is, how do we study the value of population sequencing? This is a tougher question you might imagine, because the value of a sequence, the value of your genetic blueprint, is really something that gets amortized over your whole life. Maybe it tells you about some risk of childhood diseases. Maybe it tells you about a risk of a drug that you might see at age 25 or age 35 or age 45. Maybe it helps you plan your families when you get to be of reproductive age. And maybe it helps you avoid atrial fibrillation or type 2 diabetes when you're in your 50s and 60s. How the world do you study that? All of that, which is the value proposition we're talking about. Well, we started, again, with a very simplistic idea. What if we treated genetic information as if it was a pill, as if it was a drug? Let's do a randomized trial of giving back anything you can give back in the genome. So we did this $10 million NIH study called MedSeq, where we basically treated the genome, the whole genome sequencing and genome report, as the intervention, and we compared it to people who were enrolled in the study but didn't get the intervention. We created a single-page general genome report. We covered as many things as we could. We trained up a series of primary care doctors how to read this report, because it's not natural when they first see it. And you know what? They learned really fast, and they got really excited about using it. It was, of course, intimidating at first, but they quickly caught on and enjoyed it. We once again showed that nobody freaks out, at least nobody that volunteers for these kinds of studies freaks out. We found amazing things in the genomes of ostensibly healthy middle-aged people. We found people who had mutations for hearing loss, mutations for night blindness, mutations for Alzheimer's disease, mutations for cancer risk, blood clotting, hormone deficiency, sudden cardiac death, thickening of the heart wall, abnormal bones. Now, we then zeroed in on these people and we said, well, how many of them actually already have the condition? And this was what was truly amazing. It turned out that 1/4 of them already had features of the condition and didn't realize it. And the rest of them don't have it yet, but they're being now followed in a way that can focus on the possibility that they may develop these conditions. Now, trust me, I understand this is a glass half full, glass half empty situation. You might say, oh my gosh, these poor people, they've got to live with this sword of Damocles hanging over them. Or you might say, isn't it wonderful that they can now be aware of the things that they are at risk for, and their doctors can follow them with those risk factors in mind. We also tracked the costs, and the costs were not that different between the people who got sequencing and the people who didn't. We also were the first study to really document that if you reanalyze these genomes after even just 2 years, 22% of the variant interpretation changed. That's how fast this science is moving. So it's not going to be enough to simply have a sequence done once in your life. Actually, the sequence is very good quality. You can get it done once for quite some time, but you're going to need to take that code and reanalyze it every couple years because the science is changing so fast. Well, we'd barely gotten that, some of those publications out when we got a chance to apply for a very forward-looking NIH program, and we won an award that we ended up calling the MedSeq Project, which was looking at the exact same question in healthy newborns. This was really controversial, and frankly, I've had people stand up at meetings and shout us down because they feel so strongly this is wrong. But once again, in these completely healthy babies, we are finding a whole bunch of diverse monogenic disease risks, and about a quarter of them, when we look a little deeper, already had the condition. So this is DNA screening, not purely for future probabilistic prediction. It's DNA screening that gives you a clue to a disease you had no idea was there. This is a whole new way to think about the use of genetics in ostensibly healthy people. And just to be clear, the only part of this entire page that would be picked up by a direct-to-consumer genetic test would be if one of these individuals had one of the Ashkenazi founder mutations, and that's the only one that would have been picked up by let's say, the leading direct-to-consumer genetic testing. So there's a real difference in what you get with sequencing. Once again, tremendous controversy over anxiety, child vulnerability, disrupting parent-child bonding, and we have demonstrated in this beautiful, randomized, controlled, methodologically rigorous way that, in fact, among those who volunteer for this sort of thing, it simply doesn't happen. Period. Full stop. Now, look, I don't want to be cavalier. That's not to say that an individual family might not get briefly upset. That's not to say that a particular person might get upset, even deeply upset about a particular finding. But as a group, this is simply not happening in a widespread way. And we need to change that narrative. Based on these studies, we've opened the world's first academic clinic that offers genomic screening to healthy adults and their children. There have been some large-scale commercial, very, very expensive commercial initiatives along these lines that you're probably aware of. But what we've tried to do, this is not a moneymaker, it's not scalable. What we're basically trying to do is say, let us evaluate you, and we can then offer you a menu of screening tests, which could be a lot less expensive than whole genome sequencing. Or if you really want to get a large number of genes evaluated, we can offer you whole genome sequencing from one of 2 different laboratories. And we do this with a pretty careful evaluation. We're now doing this by telemedicine. And I'm not using this talk to advertise for this, but certainly would love to hear from you if this is something you're interested in. And if we can't do it, we can tell you where you can get this done. So I asked you at the beginning to make a guess about how often you would find something important. So I'm going to refresh that screen and remind you to jot down a number in each of these boxes for yourself, and then see how close you are to at least what we found in our research. So the answer for monogenic conditions, these 2 boxes, how many people are going to be carrying a dominant mutation or 2 copies of a recessive, the answer to that depends on how many genes you're looking at. If you only look at 10 genes, about 1% of the population is going to have dominant conditions. If you look at 59 genes, we're pretty sure now this is going to result in 2.7% of the population having mostly cancer and cardiovascular hereditary conditions. If, as in our projects, you look at over 5,000 genes, we get this remarkably high percentage of 15 to 20%. And that's just for dominant. What happens if I ask you, what percentage of people are going to have an elevated polygenic risk? Well, polygenic risk means you take thousands of genetic markers, each with a very small effect, and you computationally put them all together. Most people are going to be here in the middle. There are going to be a few lucky people over here who are at low risk, and then there's going to be a few unlucky people over here at high risk. We can now identify those people who are at high risk. And if you ask, okay, what percentage of the population has about 2.5 to 3 times the risk? Here's the slice of the pie for each of these 6 conditions. And if you ask how many people is going to have at least one of those, it's going to be about 50% of both men and women are going to have an elevated polygenic risk score for at least one condition. Think about that. And then I'm not going to really talk about pharmacogenomics, but it's pretty reliable that about 80% of people have an atypical response to at least one category of medications. So I'm going to finish up now and just be very excited to enter into the discussion with you. But I do want to just say one thing about the genome. It helps us in unexpected ways. We have a whole series of publications where one of our young faculty members invented a whole new way to use genome sequencing to enhance blood transfusion. Most recently, we've been actually joining with a giant collaborative of over 1,000 scientists to try to understand the genomics of what makes somebody vulnerable to COVID-19. And there have been some genes that have been spotted that may be associated with vulnerability to COVID-19 severe symptoms. So that's very exciting, and happy to come back or talk to you offline or in another venue about that. But I would like to remind you that COVID's on all our minds now. And if you look at the number of COVID deaths per day across the world, it's huge. But if you think of it in the context of the number of cardiovascular deaths and the number of cancer deaths, these are still our major killers. And if we can reduce even a portion of those with genomics by spotting these higher risk individuals earlier and treating them earlier, I think we're going to make a huge difference in worldwide health. I'll be putting a link along with this recording that will tell you the story, 2-minute videos of some of our individual people who've learned through the Preventive Genomics Clinic. This wonderful woman tells the story of learning about her completely unsuspected BRCA2 mutation. This gentleman knew he was supposed to be getting colonoscopies at age 50, but he never had until we discovered that he had a mutation in the APC gene, and then he not only got his colonoscopy, but found some precancerous polyps. And this beautiful young child was one of the babies sequenced in our MedSeq Project, and we found a enzyme deficiency that was missed on the heel stick newborn screening. She's now treated with an inexpensive vitamin that may be preserving her from seizures, intellectual deterioration. So there are real stories of real people whose lives are being changed. And I'm super excited about the potential for preventive genomics to change your life and extend your life in the future. I'll end with this slide to remind you of our website, our Twitter handles, our Instagram, my email, and would very much invite you to follow us on Twitter and Instagram, and to check out our webpage, and feel free to write me with any questions. I'm always happy to share not only this video, but copies of these slides, our manuscripts, and so forth. So I'll stop sharing at this point. Thank you again, and Ronnie, over to you.
Robert, the one thing I can say with certainty is you will be invited back. I have so many questions, and the audience has an extraordinary number of very interesting, important questions. And we have so little time. So given that, genomics is a unique science in so many ways. It is an intimate science. Genomics is not a solo sport. When one family member learns about their genes, there are implications for every other biologic family member. When an individual patient comes to you at your clinic, in a sense, their entire family has a presence, whether they're physically present or not. What is that experience like for you? How does that affect your practice? Have there been instances when your responsibility to your primary presenting patient extends to that of the whole family?
Ronnie, that's such a wonderful topic. Yeah. In every geneticist's career, there are heartbreaking stories. I remember being on call one night as a resident, and being at the bedside of a severely impaired child with a father who confessed to me that he knew that this was not actually his child, but he was going to take care of that child anyway with the child's mother. And there are the reverse at times when genetic professionals have to negotiate around non-paternity that is unknown. There are places where one family member wants to know about a risk factor and the other family member doesn't wants no part of it. There are these very sensitive cases, and yet they have sort of the narrative of these cases, the exceptionalism of these cases has in some ways taken over the medical benefits of genomics writ large. In many, without denying the sensitivity and importance of these edge cases, it's really important to realize that so much of genomics is just like the rest of medicine. It's about risk stratification. It's about paying attention to symptoms and signs. So I think we need to rebalance the exceptionalism of genomics in a way that continues to respect these sensitive issues, but also says to people, look, this is just another part of medicine. Let's get used to it. Let's use it. I will also say that one of the failures of genetics writ large has been something called cascade testing. When we identify a woman with a BRCA mutation or a man with a colon cancer mutation, we know half of her relatives and half of his first-degree relatives are carrying that mutation. We don't yet have a good system for actually contacting and testing the very high probability that those relatives have it. There's all sorts of reasons why, but that's one of the reasons why we started Genome Medical, a 50-state telemedicine genetic counselor, genetic expert solution, so that anybody, anytime, can get hold of a genetics expert, and these people whose families are spread across state lines can readily get tested when they need to be.
Robert, in many ways, you have shared with us that genes are not absolute destiny. And you described, in fact, very clearly how possessing a dominant gene for a particular disorder will not always result in the development of the disorder. On a personal note, I work with an enormous family in Israel, 150 members of whom are potential carriers of a gene responsible for a dreadful neurodegenerative disorder, Creutzfeldt-Jakob syndrome. And when disease symptoms begin to appear, typically death ensues within months to years, and bad death. Yet within this particular family, there is one great aunt who is 96 years old and wickedly healthy. And we know of 6 other individuals in Israel who are in their late 90s who also have the gene and are healthy. Can you discuss some of the potential mechanisms of that?
Yes. So first of all, we have had to retrain our vocabularies with two important things. One, genetic markers are not deterministic. It was an accident of history that the first gene we could test for was Huntington disease. And Huntington disease mutations are deterministic. If you've got the mutation, you get the disease. There are examples of that, but they are relatively rare. Much more common is if you have even a dominantly inherited mutation, you have a probability of getting the disease. So the first thing we've had to change the narrative of is that, as you said, it's not deterministic most of the time. The second vocabulary thing we have to change is the difference between diagnosis and risk assessment. We in my profession have used genetics to diagnose people with heart problems, skin problems, eye problems, ear problems, development problems, for decades. So we think, oh, genetic test is a diagnostic test. In healthy people, that whole paradigm is different. In healthy people, what we're doing is we are assessing your risk to see if you have some of these genetic risk factors. So we shouldn't be using the word diagnosis. I'm not diagnosing you by taking your DNA if you're an ostensibly healthy person.
More to say about that at your next visit. Amongst some of the obstacles to presenting for whole genome sequencing must be fear of discrimination. And some of our audience may be aware of some of the federal protection that exists. And perhaps you could say a little about that and the limitations to the protection. And do you think at times physicians are not entering, because of this concern legitimately about discrimination, are not entering information into medical records? What is that ethical dilemma?
Yeah, thanks, Ronnie. The fear of discrimination is linked to the false narrative of determinism. If you believe that genetics is a crystal ball that tells you, unequivocally your future, then it becomes this really private crystal ball that you don't want anybody else knowing about. And that really heightens the stakes if your employer learns anything about you, if an insurance company learns something about you, and so forth. Recognizing that whether genetics is deterministic or not, it could be misused. The GINA, or the Genetic Information Non-Discrimination Act, was passed in, I think, 2008. And it protects against employers having any information about your genetics, including family history, and it protects against healthcare payers using genetics against you. The Obamacare actually built on this, and with its protection against pre-existing conditions. So you have very strong protections in those domains. Where people still get intimidated is life insurance, long-term care insurance, and disability insurance. Those were deliberately left out of GINA. However, I'm happy to report to these audiences that starting July 1st in the state of Florida, you can now have the first state of the union that has really strong protection against life insurance underwriting on basis of genetics. So you can go out and find an insurance agent in Florida today, buy your life insurance, and that law will protect you genetically.
Is it necessary to move to Florida?
No, I don't think it is. I think all you have to do is purchase there.
I know there's additionally some good news in California too, where there is some protection against discrimination in housing, mortgage lending,
Exactly.
even schools, but still we have a long way to go.
And Ronnie, I don't want to downplay this because these risks are real, but the epiphenomenon of putting this into the consent for every single person we give genetic results to has, I think, framed the narrative inappropriately. We don't say, Ronnie, I want to test you for this mutation which could save your life, and there is a very unlikely possibility that at some point in the future, your bid for life, we really downplay the benefits and we upplay the risks. And by framing that, whether it's clinical consent or research consent, we've really frightened people, I think, more than is justified. You can count on about 1 or 2 hands the actual number of discrimination cases that have been documented in the last 10 years.
Robert, I hesitate to ask such a complicated question, but I think it's so important that I will ask it even though you won't have the opportunity to respond to it in a way that I know you would like to. The issue of diversity in genomics and what are we doing about that, and also the issue of inclusivity and how do we not further divide our medical system into more of a one for the haves and the other for the have-nots.
Yeah, it's well recognized that almost all of the genetic databases are disproportionately filled with people of European ancestry, and huge amounts of NIH effort are going into redressing that, including some of the funding for our grants. Our funding for, I mentioned, for Jackson Heart Study is an example of that. It looks like we maybe get funding for BabySeq2, which would have more than 50% underrepresented minorities of the families we recruit. So I and everyone who works in the genomics research arena is painfully aware of this. And almost everyone I know is doing everything in their power to increase the access and the diversity to folks. Just in case anyone on this call is particularly interested, we actually even got a supplement from NIH. This particular one will offer free whole genome sequencing to some individuals who identify as Black, African American, or of African descent. And if you want to contact me, we have a limited number, but we can offer that. And that's an example of a supplement that NIH provided to one of our grants because we said, we're having trouble recruiting. Can you help us? And they did.
Robert, this is not a question, but a brief comment. Science is conducted in laboratories, as you well know, and that represents a kind of vacuum. And widespread application of the science requires emergence into the messiness of life. And the pristine science must be integrated into many complex, overlapping, interrelated, resistant to change systems.
Amy.
One last sentence, Glenda. The last mile from bench discovery to the bedside is not a sprint, Robert. It is a marathon. And you, sir, are running the marathon and holding the torch to illuminate the path for us all.
Thank you so much.
Glenda.
That was brilliant. Thank you both. Super fantastic. And Robert, you do have to come back again because there's so much to discuss. And this was just a beginning for us. And let me ask just a few simple questions because Ronnie and you got into the depths. It was interesting and exciting, but I'm going to get to a few simple things. Dr. Robert or Robert, what is the difference between genetics and genomics? Because everybody's asking.
Oh, great question. You know what? A lot of people use them kind of interchangeably, okay. But I mean, when I talk about genomics, I'm really emphasizing big data using many genes at once.
Okay. And would you say that getting a preventive genomic scan, would that be a necessary part of brain health? will that become a necessary part of brain health?
I think so, because whether it's Alzheimer's disease, frontotemporal dementia, ALS with Parkinson's disease, all of those conditions, we are finding out more and more about the genetics of them and some of the treatments that are being developed to prevent them or treat them are genotype specific. So we're going to really reclassify, Glenda, this is a great point. We're going to reclassify all of medicine from a category that we can see in front of us, you know, oh, you're losing your memory, to you are a, you know, PS1 mutation carrier, and we have a specific PS1 mutation treatment for you. And I think this is the beginning of reclassifying an entirely new ontology for medical diagnosis and treatment. So yes, whether it's stroke, whether it's atrial fibrillation that leads to stroke, whether it's the dementing disorders, whether it's tremor, there's so many areas of brain health. There are 67 genes associated with epilepsy and brain health there. So not to mention all the genes that influence cognitive abilities in children, autism, and so forth. So all of this, I mean, I know the hammer sees everything as a nail, and I'm a geneticist, but really all of this, genuinely, we're discovering more and more every single day about genes.
I just beginning to see this as a huge education and awareness problem, as we have in so many areas of health and brain health and human health. I liked your thought about you were studying, was it human science? How did you say it?
Yeah, human beings are the test animals in our work, and we're studying them. This is an intervention, and we're trying to prove that this intervention is safe, effective, and cost beneficial.
And really necessary. I'm interested in if all of these things are the same. One of you said that you're a pioneer in applied genomics, and sometimes you're calling this preventive genomics, and sometimes predictive. I find it all fascinating, necessary, because they have different nuances, all of those names or categories. So you're one of all of those people.
Yeah, thank you. And Glenda, the technical term for what we do is called implementation science. It's taking the technological discoveries out of the laboratory and applying them in that last mile to human beings. But you're right, we throw around a lot of words for the nuanced meanings.
Well, and in that sense, just to end that, is preventive genomics actually the definition of personalized medicine?
I think they're highly related. I see personalized medicine as a giant umbrella that is going to incorporate better monitoring. I've got a continuous glucose monitor on and an Oura ring on. I'm monitoring my health so that I can personalize, you know, as many aspects as on. They don't have anything to do with genetics. But I do see genetics, genomics, as the tip of the spear in personalized and precision medicine. Personalized medicine, precision medicine, these are terms that are being used in broad ways to describe how we utilize all the different thousands of pieces of data of your body to benefit your health. I think genomics is definitely one of the most powerful tools in that armamentarium.
And I just want to we want to keep saying these things over and over till we really understand the big umbrella, the less, all of the nuanced things. Well, I think the last thing, I want to remember to ask you about the video that you showed of the people who are learning important things from the genetic or genomic testing. But I want to tell people how they can find that.
Yes.
They click on something on our website and yours?
Yes, if I may, I'll give you a link and then Stephen can post it with this video on your website. They're on YouTube. These individuals have given full permission for the public to see their videos, and I think people will really enjoy them.
The very last thing is what keeps you up at night, and what are you optimistic about, if you would?
What keeps me up at night is how can we make this move more quickly? How can I generate the evidence that will convince healthcare systems, payers, policymakers, and even my own disciplined thought leaders, people who are in the leadership of the American Academy of, Genetics, American College of Medical Genetics, people in the leadership of the American Society for Human Genetics, that we should all be promoting this. How many lives are we failing to save because we're making obstacles to this information, because the cost of this information? How many could we save? That's what keeps me up at night. I'm pretty excited about starting with babies. It's bold, it's controversial. A lot of people are critiquing it because the baby, and there is a concern because the babies can't give you permission themselves.
Mhm.
But look, if you can learn this information early on, not only does it help the whole family, but then this child has a chance to benefit from that information at multiple steps in childhood, adolescence, young adulthood, middle age, and elderly. And just think about how that value amortizes over a whole life. So I'm very excited that and kind of amazed that we convinced the leadership of our hospital to allow us to become the first clinic to offer sequencing to parents and their children. And we're doing it with great care, great attention to communicating the risks, great attention to detail. So I'm very proud of that and excited about that.
Robert, have other institutions followed your lead in some of the preventive genomic scans and et cetera?
There are a few institutions that, as part of their executive health programs, have offered a kind of add-on for panel sequencing. And of course, we mentioned some of the commercial. There are commercial entities that are trying to sell. They're mostly laboratories. They're trying to sell these services to healthcare providers and to employers. I think all these things are good, but as you've heard today, you don't need a trained geneticist or genetic counselor for everything, but there is some complexity to this. And so we got to find the right balance between democratizing it freely and making sure that the people with complex situations get the expertise they need.
Fantastic. And I know at our earliest convenience, Dr. Ronnie Stangler and I are coming to Boston for our genetic scan for our
Great. Well, you can do this now with telemedicine. We can send you a spit kit and we can evaluate you over telemedicine. So don't feel like you have to delay.
And we also get the medical interpretation as well.
Absolutely.
By telemedicine.
Absolutely. We spend a lot of time with you. Not quite as much time as we spent tonight, but almost as much time as we spent tonight, just going over your results.
Well, thank you, Dr. Robert Green and Ronnie Stangler. Beautiful moderation. And thank you to our audience for the questions and for getting educated and updated on the new science of brain health and preventive genomics. Also, thank you to our sponsors again, Lugano Diamonds, Alpine Bank, Brain Futures, and the American Federation for Research on Aging. Also, I want to remind everyone that this session was recorded and will be available on our website, www.aspenbraininstitute.org. It will be ready and up in just a few days. You can ask for the recording. And check our website to sign up for our next episode or for the whole series. And thanks again, everyone, for coming. And ciao, everyone. Ciao, ciao. Ciao, guys.
Bye. Thank you, Glenda. Thank you, Ronnie.
Most
Keep
welcome.
up the great work with this institute, and Ronnie, with all the families you're helping. Take care.
Beautiful.